me to be here. My name is Germán Bianchi from Argentina. And here is Dr. Virendra Agarwal and Rushad Sroff. Thank you very much for coming. The first talk is about optimizing visual outcome with trifocal toric. Please, Dr. Kavita Kishi. Thank you very much for coming.
I'm Rajesh Khanna, and I'll be talking about PI. I practice in Beverly Hills and surrounding cities of Los Angeles. I don't have any financial interest other than I've written an educational book for the consumers, which is available on Amazon, and it helps the patients before and after the procedure. So PI stands for presbyopic implant in eye, and it is used to fix presbyopia, which we all know is an inability to focus at close when corrected for distance. And incidentally, it also corrects hyperopia, myopia, and astigmatism. Most importantly, it delivers binocularity, and usually we perform both the eyes at the same time, but it can also be done one after another. Now, who is PI for? It's a subset of population from 45 years to 60 years of age who can also see 20/20 with visual aids like contact lenses and glasses. They don't want monovision with LASIK or SMILE, and they are usually active, high net worth individuals who want to be free of glasses at all distances. They rely on binocularity to play tennis, golf, pickleball, ski, and yes, they are very demanding. Like our traditional goal is we feel happy 20/20, but they want more. So that's why it's a whole paradigm shift. We are not only doing surgery, but we are sort of guaranteeing the outcome to be 20/20 at distance, 20/20 at middle, and 20/20 at near. So the end point is determined first, and we should reach it in 1 or 2 steps, but sometimes 3 or 4 are needed. And understanding the needs of the patient is paramount. So we spend a couple of hours listening to them, what will make them happy, and document everything so that they don't forget what was important to them before. And also it's very important to screen out unrealistic expectations, especially in Hollywood area where they think they'll get a better role if they can see better, you know. It's good to see the structure of the eye and revisit it, the line of sight. As you can see, the line of sight passes from the tear-corneal interface to the natural lens, which will be replaced by the intraocular lens and posterior capsule, through the long sea of vitreous, and finally onto the macula. So all this must be pristine. That means the dryness must be fixed. Posterior capsule, vitreous will come to that. And remember, PI is not same as RLE. RLE is a misnomer to begin with because refractive lens exchange means we are exchanging the entire lens, whereas in PI, we know we are leaving the capsular support and the posterior capsula behind. So it's easier already for patients to understand since the posterior capsule is there, and when we YAG, what structure are we applying the laser to. And we are not just correcting refraction, but we are ensuring patient is not presbyopic anymore. For example, in an RLE, you could take a +8 patient, and this is a real case my colleague did, 30-year-old +8, made them 20/20, but they still needed reading glasses. So that's not the outcome with PI. They should be free of all glasses for most of the activities possible. And certainly it's not the same as cataract with an implant, because to begin with, cataract patients don't see better than 20/40, and sometimes they see even worse. So the base of comparison for a cataract patient for a 50-year-old who could already see 20/20 is different. So right immediately after surgery, they are comparing it with a 20/20 eye. And also the surgical techniques are different, and all the throughout the courses here, you see how difficult it is to remove a cataract. But we still have to be careful when operating for PI. Before the procedure, very important to treat dryness so we can get accurate measurements. And we have to, again, ensure there are no conflicting factors which will affect our outcome. namely performing OCT macula to rule out any macular degeneration, any pre-existing detachment, glaucoma, and also corneal thickness pachymetry to see if there's any edema or something. We have to use the latest generation of IOLMaster 700 Lenstar or similar to calculate the length, and same way for topography. And the latest formulas to calculate the exact power. Because it's just not monofocal, we are wanting at all distances. When in doubt, especially with the post-LASIK patients, I like to aim a little myopic. Because if I have to go back and do laser, I prefer PRK over LASIK because of dry eye issues, etc. And though that's also acceptable. And then with LASIK, if it's a smaller 6 millimeter wound, it heals very fast. But also, if they're post-LASIK with some asymmetric astigmatism, it also gives me a chance to enlarge the optical zone, which improves the glare halos. But yes, we are dealing with some people with high expectations who lead a very active lifestyle and not like the cataract age group. And so I warn them about negative dysphotopsia and to ignore that from the beginning. Positive dysphotopsia or glare and halos occur more often. Like negative usually disappear by 4 to 6 weeks. But glare and halos, mostly they disappear by 3 months, but some few 5-10% remain till 1 year. At least 2% in my practice we've had where they've gone on to 2 years. At that time, after 1 year, I give them the option if they want to go in for a lens exchange or something. But then they say, hey, no, we are happy, it's getting better, we are waiting. And by end of 2 years, I don't have anybody who is still having glare. But most importantly, because they're going to compare, especially when we are doing a couples, husband and wife, one gets to 20/21 and the wife is very unhappy. So we tell them each person is different because also neuroadaptation is required. So just the way we are hardwired, we might come to this same result at different times. Though the surgery is not very complicated, we have to, based on our calculations, place the incisions very accurately. And it's very important the rexes be 5 to 5.5 millimeter to cover the optic. Otherwise, there can be astigmatism created, and also the anterior capsule can fuse with the posterior capsule if the rexis is too big, and if it's too small, phimosis can occur. Then hydrodissection and delineation are important because the lens is not very hard and it tends to jump. And so we have to be careful not to go near the capsule. And the typical techniques of chop and may not work because the lens is softer, so we have to use a combination methods. Now I'm just playing this video to show because I'm putting through 2.2, patient is awake and they have to be very cooperative to give patient assistance. If they don't, then I enlarge the wound. And also to make sure astigmatism by different techniques we are using, veracity, etc., is placed.
Would you wrap up, please, sir?
Oh, we didn't start at that time.
I think time is...
Yeah.
Try to finish fast.
Oh no, it never started.
No, it was there. We were watching.
It was?
Yeah.
I have gone only half because I have timed this. It goes to 8 minutes. Right? This
Yeah,
never started.
time supposed to was be 8 minutes. You can take 1 minute because time is over, so but we can give you 1 minute. So be
Okay.
fast.
I don't think it started. No. It was started? Yeah. Okay, well, I'll take 2-3 minutes extra then we have to remove all the viscoelastic just to show some expectations.
Hi, my name is Kevin, and I had my pie surgery. Hi, my name is Kevin, and I had my pie surgery yesterday. I was able to drive myself today. I've been able to see 20/20 today. It's a great blessing and a benefit. It's something I didn't think was possible.
So they're driving very fast, and as I was saying, we are just looking at 2020, but they're
Hi, my
looking
name
for
is Mary
different things.
Ellen, and I had the PI surgery with Kana Vision Institute, and now I have perfect vision. I had excellent care. They took great care of me. I was able to go back to work the very next day after the surgery, and my pickleball game has improved a lot.
So beyond 2020, they are looking at other activities should improve. And just to go fast, posterior capsule is something which we treat differently, even for few cells or wrinkles. Rather than just opacity, we will react to get the best outcome with these implants. And again, vitreous has been neglected, but now Dr. Steve Safran and others have emphasized, and we've been doing for 6-7 years, to clear any floaters which are present in the line of sight. And that helps a lot of patients which we previously neglected. So that's it. And this is how you can contact me. Thank you.
Thank you, Dr. Rajesh. So how you feel it is different among the other trifocals or bifocals or lenses?
So the lens, choice of lens will keep changing as the technology comes, but the philosophy remains same. Right now I'm using Technics Symphony
Synergy.
OptiBlue.
Okay.
OptiBlue because that's giving the best continuous range.
But the Synergy is giving more range instead of Symphony.
So that's a very good question. When Synergy first came out, our European colleagues were raving about that. But in Los Angeles, people are driving at 80 miles per hour with all the lights, and they want very good distance. So Synergy, the distance was a little compromised. So I have to keep listening to what the patients are saying and adapt faster. With Symphony, previous version, there was a lot of cobwebs and they were unhappy.
Yeah.
That time I was using a combination of Technics 325 and 275.
Okay, yeah, multifocal
But with
and-
Symphony, OptiBlue, and again, I do a lot of things like measure the height of the patient. If they are tall, they
The
go
all
to
arm
really-
length is important.
Yeah, and what activities they are doing, if they are doing crochet, then we can adjust.
Definitely.
But that's why expectations have to be
But
dealt
my
with.
experience with the distance vision is not a compromise in Synergy also. I think you try again and you can use one eye Symphony, one eye Synergy. That will give you slightly
Yes,
better.
that's what I'm saying. Combinations will keep
Yeah.
changing.
Yeah. Thank you very much. So now we invite Dr. Kavita, and she is going to share experience for optimizing visual outcomes with trifocal toric.
Thank you, sir. A very good morning to one and all present here. At the outset, I'd like to thank the organizers for this great opportunity. And my topic would be how to optimize a visual outcome with toric IOLs and also trifocal torics. So one of the most happening things in the world of cataract and refractive surgery is the evolution of IOL as toric intraocular lens. And we all know that cataract surgery is no longer a visually restorative or a rehabilitative procedure, but a highly revolutionized and evolutionized refractive procedure. So I have no financial interest in any of the products mentioned here. And this is a study which was conducted in a tertiary care center in North India, where most of the cataract patients had, sought admission for cataract, and it was found that more than 40.49% had an astigmatism of more than 1 diopter cylinder, and most of it were with the rule, and it advanced to against rule with age, and against rule astigmatism was highly prevalent, and multiple studies do support that toric IOL implantation results in excellent visual acuity than implantation with a non-toric intraocular lens. When it comes to addressing the spectacle lenses, we always make sure that we always correct spherical as well as address astigmatism as well. But when it comes to managing patients with cataract and astigmatism, so not all surgeons are doing the same. So are we intimidated by fancy terms like postercorneal astigmatism, centroid SAA, or true K values? Or are we intimidated by incredible diagnostic tools, markerless onlays and corneal tomography, which we feel that it is definitely mandatory to implant a toric intraocular lens? Or are we overthinking that the fear of realigning the misaligned axis will be there most of the time? So in the next few minutes, all these myths will be demystified. So one important quality we all need is an eye for perfection is very, very important, and consistency and reliability is also important. And this, especially when we are implanting, whether it is mono or trifocal torics or EDOF torics. So careful consideration, all these, and every step will definitely avoid these stacking errors and a domino effect. So proper preparation always prevents poor performance, the 5P mantra. So a pre-operative evaluation thoroughly assess the patient's visual needs and set the patient's expectation at the right level. So in this regard, what we do is we follow a simple questionnaire to assess what is his need, whether he drives a lot and whether he had undergone any LASIK surgery, because those patients had valued spectacle freedom so very early in their life. And so it is very important that we give good importance to this fact. And enough chat time to counsel, the preoperative period helps us a lot. So we need to clearly nail the fact that there is no single IOL which can give excellent range of vision and also excellent contrast. So also we'll have to prepare the patient for what to expect in the post-operative period, like neuroadaptation, and that the night dysphotopsias all will be common, and that they need to have adequate lighting for their reading, and their reading distance may recede. So exclude all the comorbidities as much as possible, especially progressive zonulopathy, which gives an unstable bag. And dry eye evaluation, I like to stress and give a lot of importance for this. Even if it means waiting for 6 weeks to treat the dry eye, it definitely matters. It avoids post-operative surprises and disappointments among the patient. And we win the trust of the patient, and they become our brand ambassadors. And accurate biometry even before a puff of air strikes the cornea or a drop falls into the eye. And apart from the routine retinal evaluation, OCT macula, to look for subtle macular pathologies is important, and the corneal tomography throws a lot of light on aberrations like coma and ascertain the regular astigmatism and angle kappa, alpha, etc. So in the preoperative challenges, calibrating every tool, every diagnostic tool is of paramount importance, and that has to be done regularly to give and enhance our visual outcome. And this is not just an ordinary task, but a Himalayan task. So a small change would be to do the keratometry and biometry first and then start your counseling, because we know whether it is, they do have cataract and astigmatism, and whether it is regular astigmatism or with the rule or against the rule. And our threshold should be as less as 0.5 diopter in case of trifocal intraocular lens against the rule astigmatism, and exclude these extremes of diopters as well as high axial myopia. And these are all some of the relative contraindication. Last but not the least, patients with the right attitude is a must, and so always under promise and over deliver. So factor in SIA, and it is unique for each surgeon, and even for the same surgeon it differs from right to left eye and for the incision size. So till you calculate, you can have an average of 0.1 diopter, which is a very good estimate of centroid SA, which factors in both magnitude and direction. And the posterior corneal astigmatism also has to be factored in, because it corrects, it acts as a negative lens, and it overcorrects the with the rule and undercorrects against the rule astigmatism. So till we do have access to high-tech devices like IOL Master 700 and other things, which measures the true K values, Barrett's toric calculator is definitely a boon, because we have a study which had told that astigmatism prediction errors based on IOL Master 700, both with and without measured posterior corneal curvature, were similar. So which formula answers the next question? Definitely the Barrett's is a boon, but you have to appropriate the right formula for the right patient. We have an array of those formulas here, and most of the lens manufacturers have incorporated this Barrett's 2 algorithm in theirs. And it is also important that instead of taking an average toricity ratio, which is actually the ratio of the toricity of cylinder of the IOL at the IOL plane to that of the corneal plane, in extremes of eyes, we do have to follow the nomogram and fill in those. So again, the choice of the lens, make sure that it has excellent rotational stability, and proven biomechanics and proven biomaterial is important so that it stays right where you want it, and the stable force haptics also has to keep it centered in the capsular bag. Well, my choice of trifocal IOLs is the trifocal toric Zeiss, because it gives excellent 4-point haptic design, excellent rotational stability, especially in high myopes where the bag is really very big, and due to various other factors like asphericity, and it's also a preloaded one. So after you determine your calculated power and other things and determine the IOL model, our next thing is the actual surgical step. So the procedure is essentially the same as routine cataract surgery, but if you're going for a manual marking, make sure that the cornea is dry because it doesn't smudge, and also make a well-centered, perfect capsulorhexis so that there is a 0.5 overlay over the lens and it stays right. Well, and also this phacoemulsification, make sure that you don't have any wound burns or other things as well. Just a half a minute.
Yeah.
And then you also make sure that the incision should be the right size incision and the cartridge should be the right cartridge, so that whether it is in the wound or wound assisted, it should not distort, and unnecessarily iatrogenically we should not induce any bizarre astigmatism, and this is done. So a spot on accuracy, whether it is manual or with a markerless only, it definitely markerless only, and IOL Master 700 does contribute a lot to enhancing our precision. But still we can get a good result even with manual marking with a spot on accuracy and perfection. So the trifocal IOLs are for those eyes at refused age, and thank you so much for your patient listening.
Thank you, Dr. Kavita. I have pleasure to invite Dr. German Bianchi from Argentina, who have won the World Cup.
Yes.
And we all ophthalmologists know the Argentinian flag sign. So he is going to speak about the sulcus anatomy and the role of it in phakic lenses, and particularly the phakic lenses for presbyopia. Over to you, sir.
Thank you very much for the invitation, and I'm so happy to be here and proud to be here too. Today I will talk about the anatomy of the sulcus, and implanting the phakic intraocular lenses are an efficient and safe option for correcting myopia, but we need to know with the preoperative evaluation how is the anterior segment and how is the posterior chamber too. And we need to know the eyes characteristic and the phakic IOL characteristics too to have a good postoperative result. And I think this is one of the most important things, to know everything about the eye. We need to know with the slit lamp, the eye surface, the wide to wide, also the UVM, because many of us that do this kind of surgery don't do the UVM, but we put the lens in the sulcus, and we need to do this study. Because sometimes I found some cyst in the sulcus. And of course, we need to preserve this human aqueous circulation in the eye. And why UVM is important in the pre-op evaluation? I started to study the prevalence of cyst time ago, and also we need to know also that the vault of the lens is not static. It's not just a number, it's dynamic. We know that with the photopic light and scotopic light are different, like we can see here with the IPCL. I found after 2 years of follow-up that the shifting vault was a little bit less of 100 microns. And also, I studied the prevalence of the cyst in the sulcus, and the prevalence was very high. Near 55% of my patients has cyst in the sulcus. This is because we need to know how is the sulcus, and 82% have cyst in both eyes. And I also continue to study the cyst and the vault, and I realized that I present that study in ARBO the last year, and well, I realized that the perfect bolt is between 400 and 600, and this kind of patient don't have cyst in sulcus. The other have more number of cysts. And I also studied that the patient that has bolt with more than 750 micras have more cyst in sulcus too. And all of these things are important, and also it's important how some difference between the different kind of IOL tooth. And this is a retrospective case series study that is in peer review right now, and I found the IPCL was, the bolt after 5 years of follow-up was stable. Don't change the bolt. The bolt with more than 750 changed just a little bit. It was reduced just a little bit. And I also studied the intraocular operation and the endothelial cell density, and it was stable in all of these cases. The lesson learned along the way is that this is important to know because we need to prevent complication in these patients. I found rotation in some patients, and in all of these patients after surgery, I found cyst in sulcus too. This is another reason to know how is the sulcus in these cases. This cyst sometimes produce this movement in the eye of the IOL. And the low bolt also, I found some patients with low bolt, some patients with cataract in these cases, and some no. And some patients also with this capture of the pupil with high bolt. And all these complications, we need to know how is the anatomy of this kind of sulcus. And also, I found some cataracts. This is important. The central hole, I found cataract with the model V1 because the circulation of the humor aquosus sometimes is not good in these cases because this kind of IOL don't have the central hole, and sometimes produce some vacuum in these cases. And it's important to know also that if we need to take out the crystalline, the cataract, this is because reduce the visual acuity. If not, it's better to preserve the crystal.
We have evolved from trabeculectomy to MIGS. Now MIGS is a group of surgeries which have very high safety profile and with minimal disruption of the normal anatomy. It has ab interno approach, that's why it can be dealt along with the cataract surgery, and it's quite easy to use with good efficacy. When we talk about MIGS, there are different types of MIGS. One is to enhance the flow across the trabecular meshwork, through ab interno route. The other one is to augment the uveoscleral pathways, and third is to cycloablate those ciliary processes. What we are talking today is only by enhancing outflow, which can be done along with the cataract surgery. Well, angle surgery has been a recent phenomena for the adults, although we have been doing it for children for many ages. So here I'm going to talk about three things, that is iStent inject, KDB goniotomy, and bang. Well, the general principles being that
both hydrophilic and hydrophobic elements being there, the idea is to give us the best of two worlds. It has a high refractive index and double square edge. I don't know whether it contributes towards that or not, but with these lenses I have found very, very rare incidence of negative dysphotopsia, but I don't know whether double square edge actually contributes towards that. And it is preloaded, reducing the contamination. Now the advantage of getting the best of two worlds is we do all know what a hydrophobic does to us and how has it helped in our practice. With a hydrophilic material being there, it just sometimes is easy to take care of the intraoperative incidents like this IOL. While it was going in, it just flips over, but half of the IOL is already inside the bag. So if it's hydrophilic, at least a component of that is there. It's so soft that it can be toppled back right inside the bag. It just takes it takes a span of 2 to 3 seconds, and then you put it in. I don't know whether you can appreciate the central zone in here. I've tried to highlight that with the help of the red glow, but it's so thin, and I better be an eye which doesn't need the services of a toric. Thank you so much for your attention.
Thank you,
And
sir.
I think I finished well with the time.
Yes. Yes. Thank you.
Thank you for that.
Sir, so what is your preferred choice now? To give a patient good distant and near vision, would you go with trifocals, or would the EDOFs be a better option for you? And how do you kind of choose which patients to do what in? Meanwhile, can we have the next speaker, Dr. Amit Kiran? Can you yes, sir.
Let me tell you something very, before I begin even addressing your question, Rushad, that all the EDOFs and TRIs with their non-torics and torics are placed at the same price point at my hospital. We have the same packages for these and these, so that the choice is completely left on to me to decide which IOL is best for that particular patient. I look at a lot of things. One of the basic things is the pupillary size, the age of the patient, of course the lifestyle, we all look at that. The angles, I don't believe the alphas and the kappas should not take a call on which IOL should we be choosing. I'm a very strong believer that people burn their fingers if they do not look at the alpha and the kappa when they decide on these lenses. So looking at all these, if the patient qualifies for both, then I'll look at the gender and the lifestyle. If not, then I'll stick to one product, whichever is the best for the patient. If the patient qualifies for both, and look at the gender and the males generally do better with the EDOF. Females generally do better with the TRIs. That being said, I do not believe in micro-monovision at all. I prefer to leave my patients absolutely emmetropic, and I would love to have all three distances clear without any residual myopia, because I don't believe that even if the defocus curve has a flat top, if you left shift it, it does not affect the quality of vision. It does.
Thank you, sir.
Thank you.
Over to Amit to share his experience and give a talk on Orolab Essence, the essential choice for optimal outcomes. It is a kind of enhanced monovision.
Yes.
Yeah.
So good morning everyone. At the outset I would like to thank AIOC for giving me this opportunity. I don't have any financial interests. So the first and the most important thing, why do we require advanced monofocal or EDOPS thing? Because there is, as we all know, there is increase in the aging population, but not only increase in the aging population, but their active life, there is increase in the active years also. These aging people, they are more and more active now. They are indulging in social media, WhatsApp, Facebook, they are driving. Driving is not an issue, but nowadays Google Maps is important. So watching it on a Google Map and driving, this is something which require more than a monofocal. So Lindstrom stated long back that the most common complication of pseudophakia is a presbyopia. And in order to overcome it, we are trying hard since years. But right now we are having only three options. Either to go with a monovision, maybe micro, mono, mega, but monovision, then do with a multifocal, either bifocals, trifocals, or else to go with a EDOF. So we are having only these three options right now. But why do actually we require these EDOFs or modified monofocals? Because all the patients, they desire to do all the things without the glasses, and at the same time, they are not all suited for the trifocals. The window of contraindication is very narrow in cases of trifocals or multifocals. So nowadays, in order to overcome, every day or another day, some of the Indian or multinational company, they are coming with a new IOL, with a new technology, claiming that our IOL is the best IOL, and so on and so on. So does it really help me in my decision making? No, actually too much of options, too much of knowledge lead to too much of confusion. To add to it, again, why we want a new lens? Why Orolab Essence? The answer is very simple. The first and the most important that it is coming from a Orolab. And as we all know that the Orolab is one of the most trusted and time-tested brand, not only India but in all over world. So if something new is coming from the Orolab, it has to be tested. Secondly, it is a modified monofocal, which gives you all the advantages of monofocal, less the disadvantages of trifocals. And the most important, it is very, very cost effective. Orolab people put price around 4,000 only. So in a price less than the imported monofocals, if I am getting advantages of modified monofocal, then why not to go with the Orolab Essence? So why they call it as a revolutionary advancement? The most important thing, this lens gives you crisp distance vision. For me, intermediate or near, they are secondary. For me, what is more important, my patient should not feel any difficulty in a distance vision. His distance vision has to be crisp. No photic phenomena, no glares and halos and no black shadows. That is more important for me. In addition to that, it gives excellent intermediate vision from 70 centimeters onwards with no diffractive rings, zones or bumps or anything that is visible to our eyes. So there is no questions of glares and halos. So how they have achieved it? They have kept the anterior surface of the lens totally aspheric. They have made some modifications on the posterior surface that gives elongation of the focus, extended depth of the focus. So this anterior surface, they keep the monofocal lens-like properties, while on the posterior surface, they have made some changes in the central 3.2 zone, which gives elongated focus. So continuous range of vision from 70 centimeter onwards, while keeping the standard monofocal vision. The standard of monofocal vision has not been compromised. So from center to peripheral 3.2, they have gradually increased the power with making continuous range of vision. So it is just like as a progressive lens. So coming back to my experience, here initial assessment we have done on 30 patients with an average age of 54 and post-op evaluation at the 1 month. So any motivated informed patient who is eligible for monofocal, the only thing is that having cylinder less than 1 has been selected for our studies. In our studies, we have selected 2 one-eyed patients also, and other patients having monofocal in other eye also have been selected in this study. Initially, we excluded the patient having some retinal issues, but when we analyzed the results after 1 month, we came to know that we can include some early retinal patients like early ARMD changes also, because the contrast is very good. So nothing special in preoperative evaluation. We have used Barrett's formula, optical biometer, and we have targeted either plano or first myope. So regarding distance visual acuity, uncorrected we got 53% 6.9 and remaining 47% 6.6 or 6.6 part. Regarding near vision, we got almost 27% with N10 and 73% around N12 with one eye. So I strongly believe if we put it in a both eye, bilateral, we can easily get a good functional near vision around N8. So near eye we required was for almost 83%, it was around 1.75. We have tested this intermediate vision on Sloan chart and we found that 0.2 logmar was achieved in 53%, which I think is a very, very good benchmark for the intermediate vision. Spherical equivalent required was only 0.5. Defocus curve, as you can see, from +1 to almost -1.75, we are maintaining the logmar of 0.2. Again, contrast sensitivity for this study purpose, we analyzed the contrast on a vector vision chart and we found that for 3 spatial cycles, we are getting in a mesopic and photopic a very good contrast. To make it simplify, we have plotted on eye tracy also MTF, and as you can see, for the 5 spatial cycles, we are getting 0.8%, means 80% of contrast we are getting to 5 spatial cycles, while for 10, we are getting almost 0.57. So to make it very simple, as you can see, there is a red box, which is around 40%. So anything that lies above the red box, above the 40%, has been considered as a very good. And as we are getting 80% of contrast, it is almost as good as a monofocal lens. Now to summarize it, we are getting a superior intermediate vision without compromising the distance vision. It is more forgiving even if we miss the target by 0.5 or 0.75. And at the same time, it is not inducing any spatial aberrations. So it is almost equal to natural spherical aberrations of a human eye. Again, it is not a pupil dependent. And it has, so as it is not a pupil dependent, even if we little bit decentered here and there or lens tilt is there, it won't going to hamper the patient's post-operative outcome. And it comes in a fully preloaded system. It is available from 5 to 35. So to conclude, as we all know that the no lens technology is perfect replacement for the natural crystalline lens, but we are trying to bridging the gap between the monofocals and as well as trifocals. So if time permits, can I show this small video? This is a small video how it comes. It is a fully preloaded system, as you can see. We have to just put the visco. We can see under microscope actual how the IOL is aligned. If we see something, we can adjust it with the MacPherson's also. We have to just close it, put the visco and inject inside the eye. See, this is a protective cap. We have to just remove it we have to close the cartridge and just we have to inject it. So as you can see, I am doing hydro implantation. This is a 2.2 incision, preloaded incision, and you can see how smoothly it is going inside the eye. It goes very smoothly, it unfolds very gradually, smoothly, and the most important is this is a Aurolab platform, we all are familiar. I don't think there is anyone from Srinagar to Port Blair who have not used any Aurolab lenses ever in his lifetime. So it is nothing new. But for the first time, they have introduced 2.2 preloaded system. Otherwise, they were having 2.8 preloaded system. But for this lens, they are providing 2.2 system also. Again, the fallacies I thought toric lens about, but they are bringing toric lens very soon. Maybe the next month, toric version of this lens is also will be available. And second thing, as it is a initial, so sample size is very small. We need to study across at least another 6 months or 12 months and a bigger sample size. Thank you.
Thank you, Amit, for sharing your experience about a new lens on the platform available for all Indians. And we all know Aurolab is a good company, so there is no issue.
Yes.
And now you all see that the refractive surgery changing from examer to femtosecond and lenticular removal is the in thing, and many companies are now offering. So let us hear from a very good surgeon and from the family, Rushad Shroff, about his experience for the Silken Touch lenticular extraction made easy.
Thank you, sir, for that kind introduction. So this is, we are doing our lenticle extractions on the Elita platform from Johnson & Johnson. The key features of this platform is one, it's a very low energy laser. It's one of the lowest energy lasers out there in the market. It's an extremely fast laser with a 10 megahertz repetition rate, and the spot size is very small with almost no spot separation. That ensures tissue bridge free dissection of the lenticule. The other unique feature of this is the biconvex shape of the lenticule. This has been shown in confocal studies to cause less damage to the subbasal nerve plexus. There's better matching of the anterior and posterior lenticule surfaces, and when we looked at OCT to see Bowman's wrinkles that affect the quality of vision, we did not find them to any extent in this particular technology. And it has a non-refractive flat ad with a ring cut, which makes it easier to actually remove the lenticule. So with this in mind, we were one of the first sites to do the limited market release for this, and these are a few of our learnings. One of the things about femto lasers is that each laser is different. Each laser's glass burn threshold from where you set the energies is different. So it always takes you an initial few cases to get your energies optimized. The general principle is to go with higher energies and then come down on the energies.
Silence,
and that makes
please.
the dissection a little bit easier. This is a video just showing that the optimizing the ocular surface is very, very important in lenticle extraction procedures. So you have to not leave the surface either too dry or too wet. It's important to use a Vexel sponge to optimize the surface before firing the laser, as well as before extracting the lenticule. Regarding the dissection technique in this, it's pretty similar to the existing lenticule platform from Smile. The only thing is, because of the biconvex shape, it's important to tent up a little bit more. It's kind of like kicking a football when you enter the anterior plane. And while going into the posterior plane, it's like diving into a swimming pool. You have to dip down a bit more. The rest of the procedure is fairly similar. It's, as you can see here, the dissection is relatively easy. There's not much resistance being faced, and you can clearly and easily see that it's being dissected out in pretty much 1 or 2 sweeps. It's always important at the end to inspect the lenticule just to make sure that you've got the lenticule out completely and there are no tags or remnants. And in the cases we've done so far, which is about 105 eyes, we haven't had any retained lenticule in any case. So coming to the meat of the talk, which is our results, it's important in these technologies to assess efficacy and safety. What you can see from our data is that 95% eyes were 20/20 or better at 1 month post-operatively. In terms of the safety, there were no patients that lost 2 or more lines of vision. There was a patient who had a epithelial defect who lost about 1 line of vision at 1 month, but no one with 2 or more lines of vision lost. The accuracy of the spherical equivalent attempted versus achieved, as you can see here, it's quite tightly packed. The initial nomogram, there was a little bit of undercorrection, but with the subsequent iteration, that got better. And as you can see here, the percentage of eyes within, this is taken on the autorefractometer, within 0.5 diopters is 67%, and within a diopter of the spherical equivalent is 90% at 1 month post-operatively. In terms of astigmatic correction as well, you can see that 75% eyes were within the targeted 0.5 astigmatic correction, and 97% eyes were within 1 diopter of the targeted astigmatic correction. Another bugbear has been the recovery post-lenticular extraction surgery, and we can see here that there is a fairly good recovery. The average uncorrected visual acuity is about 0.1, which is not bad. That's about 6 by 7.5. And what we did was we actually divided these eyes into learning curve and non-learning curve eyes, and you can see that it's come down from about 0.15. In the next 85 eyes, it's almost at 6.6 on the first day. So after you get over your energy optimization and your learning curve, you actually manage to get pretty good wow effect or good outcomes on the first day itself. Regarding aberrometry, we looked at the iTrace system, and we found that there's no significant induction of aberrations, again, which is very important in a refractive platform. In fact, there is a trend towards reduction of corneal spherical aberration, and this provides excellent quality of vision to the patient post-operatively. There was no induction, significant induction of coma or trefoil in these patients. And this is just an example illustrating the same on the iTrace system. This was done at a 5 millimeter pupil size. And this is a graph just to illustrate the same. Regarding contrast sensitivity, as was shown by my previous speaker, there is a slight decrease in contrast sensitivity, but again on the iTrace at 10 cycles per degree, it's maintaining more than 50%. So that's a pretty good contrast, and it's not a significant drop in contrast in these eyes. We also looked at dry eye data and found that the lipid layer thickness and the non-contact TBUT were a little bit, were well maintained. Again, no significant change in this in the post-operative period at 1 month. We also looked at the ocular surface thermography. That's another device that we are using to study the ocular surface temperatures. We did a small study comparing lenticule and flap, and you can see that blue tracing of the lenticule, the severity score or the impact on the ocular surface immediately post-operatively dips down, and even at 1 month, it's below the baseline. So it's maintaining the ocular surface better, whereas in LASIK, it tends to go up from baseline, showing more impact on the ocular surface as is expected with a flap-based procedure. To take home, basically the points are that the ELITA system has a short learning curve. We've found excellent immediate post-operative visual recovery. There's no significant induction of aberrations. There's no significant increase in dry eye. The thermography is better than flaps, so the ocular surface is better maintained. But like with any laser, it's important to understand your laser, modify the energy settings and dissection technique and instruments as per your comfort. Thank you.
Thank you, Rishat, for sharing your experience about this technology. May I have a question that how many patients you think now will shift from excimer to this lenticular extraction technology?
Sir, I think lenticule is going to be the future going forward. However, at this point in time, there are still a subset of patients where you will require eximers. So these are complementary technologies. You can't say currently that every patient can be done on lenticular extraction platforms. A lot of surgeons are doing predominantly lenticular extraction, but in our practice, I would say it's almost a 50-50 right now. So
Yeah.
there are cutoff criteria for each procedure.
Yeah, now it is not the day the exam will go away. Definitely, if hyperopia is coming with the lenticular, then it will have more number of patients. And there are other issues like cost is also issue in India
course,
particularly. And examiner is not doing bad results. It is giving very good, excellent results.
Exactly.
So it has to stay. Yeah,
It's
I
there
agree
to
with you.
stay.
Thank you.
Yes.
Like for smile, we have 250 micron, like 120 micron below which.
Yeah. So this cap that we had set in these patients was 110. You can set it a little bit deeper, but for the initial recommendation from the company was 110, and that's what we've actually used so far in these eyes.
For smile, we have plano cap. Here we are not having a plano cap. It is thinner in the center and thicker in the periphery. So if you go deeper, you will go more deep in the area where you are going to have dissection. So it is better to keep 110 in this, but smile you can go up to 120, 130. I commonly use 120 for smile. Yeah.
Thank you.
Any questions? We have just 2 minutes. No, 11:15 is the next session. I am the first speaker, so no worry. I am here only. But any questions, any comment from the audience? But I think the time has come when the cataract is becoming refractive surgery, so these kind of sessions are of very important. And I think I must thank Dr. Bianchi for giving importance to sulcus examination before implanting a phakic lens. I was just doing personal discussion for the cyst in the iris. If we can localize it well, and he agreed to it that we can do a peripheral iridectomy over the cyst, so it will get plain. So in those cases, it can be of help. He said that I will do a study on this, but this is one idea. Anything you want to comment on, particularly MIGS for cataract surgeons? I think many patients of cataract, even preoperatively, are not having controlled on 2-3 medicines for glaucoma. So it will be good that if we all can learn from Dr. Sushma to do MIGS or take a help from the people who are in and around your practice for doing the glaucoma management along with the cataract surgery. I think that is a very good approach. We had a very limited experience with this, but we found it works well. We used mainly the 25 gauge needles, and we have used stents also, but we have not used any KDB. But I think cost is an issue for KDB, so the Indian replacement of needle will be very good approach. Thank you very much for all the panelists and the delegates who are having here, and I invite for the next speaker session people and chair people on the dais.